Now to our second speaker. No one knows him. Dr. Abdessalam Abu Libdi. He is also a graduate of Maqasid Hospital in occupied Jerusalem. For our visitors, it's occupied Jerusalem. It's not Jerusalem, it's still occupied. Send the message to Italy and to England and to America and to Trump and Pakistan. And this occupied city is, I don't know, he's a dog somewhere. In spite of the occupation, this holy city is producing really an excellent physicians and people and fighters. And Dr. Abdessalam, start the Maqasid experience, please. I don't think I need to say more about you, right?
Thank you. I will not say I will thank the organizing committee and thank myself. So like always. So I will take today, everyone is asking me to make my lecture very quickly. So I will talking about Maqasid experience since and I have started since 2009. So it's about 11 years of experience with a tertiary hospital, having patients from all over Palestine. So I will do my best just to taste what we are doing at Maqasid Hospital. Before I start, this is Maqasid Hospital. For those who don't know, it's in the Mount of Olives in the Jerusalem. And this is the view from Maqasid Hospital. And this is the view from my window of the clinic. This is the soldiers that they invaded the hospital to check, as they say, suspected patients. And it was here, we were standing here just in, asking to prevent these soldiers from entering the hospital. Back to endocrinology, if you know this guy, this is Franco Cirelli, who's sitting over there. And we were in a conference in Saudi Arabia in Jeddah, and he showed his gifts in endocrinology and diabetes, and also I was finding that he can dance fluently even in Jeddah. So, and I asked him about him.
Don't tell my wife.
Exactly, this is the secret. And another thing I have learned from him that whenever I say that you visited countries, some of you, how many countries you have visited in the world? Maximum number, 10, 15, 20? No, you. Yes, anyone. How many countries you have visited all over the world? How many cities? Franco, can you give the answer? How many countries have you been all over the world? Yes, so 195. So 196 countries he visited. He's now working with the WHO, and he's now he finished that recently, and he said, I have finished the full map. So now he's discovering more countries. So this is Zulf. He left us Zulf, and he was dancing also with us. So endocrinology is not always talking about science or talking about genes or Khalid. So I don't have a picture for you, so I will keep it for the future. And when talking, I want to talk about introduction. Dr. Mahaki said about introduction, about monogenic diabetes and how it can be classified, transient or permanent diabetes, about 45 transient, permanent, and talking about syndromes. And these are classifications, how to use it, and just to simplify, how to diagnose your patients according if you have deafness or anything, just to simplify, how do you go for early diagnosis. So when talking about monogenic diabetes, either talking about abnormal pancreatic development or beta cell function or destruction of beta cells. Maqasid, as I told you, it's in Mount of Olives. Our objective was to determine the genetic mutation pattern of suspected cases of monogenic diabetes in patients referred to our hospital. Molecular detection has been done for those infants who were fulfilling the following criteria: transient neonatal diabetes, permanent, infants with diabetes diagnosed between 6 and 12 months of age, and negative antibodies, infants with diabetes associated with extrapancreatic features, infants with diabetes presenting before 6 months of age, as if type 1 diabetes is extremely rare in this group. The first case, this was the first week that I have started in 2008 at Maqasid Hospital. So we'll make the story short. He was an IUGR, a male, when he developed diarrhea and he developed sepsis and died from sepsis. The problems listed were for the first patient as a neonatal diabetes, enteropathy, sepsis, metabolic acidosis. So we have to think about IPEX. So IPEX, at that time, we sent the mutation to extern, and they gave us that the patient is hemizygous for a novel missense mutation. So IPEX, if you can appreciate that immunocirculation, polyneuropathy, enteropathy, X-linked, and it's about 4% of cases of males with permanent diabetes due to FOXP3 gene. The second case came from Gaza. So it's as a case of type 1 diabetes, hypothyroidism, failure to thrive, elevated liver enzymes, and short stature. After evaluating the child, this can we appreciate. We are in the Middle East and in a consanguineous, very high consanguinity in these families. So we can appreciate in this family pedigree and the consanguinity. And this is the child. Are the features, the X-ray, and this is his investigation showing that systemic disease with the short statures. So this child has early infant type 1 diabetes, hypothyroidism, multiple skeletal epiphyseal dysplasia, short stature, failure to thrive, elevated liver enzymes, and hepatomegaly. So this led us to the diagnosis of Walcott-Radisson syndrome. So she has mentioned Walcott-Radisson syndrome, just be kept in mind, and it's really, it is present in the Middle East, as we have heard from previous lectures. The third case, a 5-year-old presented with also consanguineous Palestinian family, neonatal diabetes, bilateral cataract, deafness, left hydronephrosis, failure to thrive, microcephaly, severe psychomotor retardation, seizures, severe scoliosis, and contractures. We did investigations, and this patient, this is the problem list: persistent neonatal diabetes, cataract, deafness, hydronephrosis, seizures. Of course, we have to think of DID mode. So we had whole exome sequencing at that time. We did the whole exome sequencing. At that time, it was transitional period, doing item mutations at Maqasid molecular lab at Maqasid, or sometimes doing whole exome sequence, depending on the situation. And we had the sequencing of these patients having a heterozygous missense mutation. This is another patient that presented in the neonatal period, and this it is not the usual presentation that usually present in the DID mode in the neonatal period. And our propand, the age of presentations was 40 days diabetes mellitus with optic atrophy, deafness, diabetes incident, there is no, and growth retardation. And this is our comparing into the classical Wolfram syndrome. So we have Wolfram syndrome, a novel de novo dominant mutation presenting as unusual clinical phenotype. These cases also presented in the same family, that 3 sisters, and they presented to have diabetes, diagnosed at age of 5 years, ophthalmic exam showed optic atrophy, neurogenic bladder requiring frequent catheterization, and polyuria and polydipsia. Of course, we thought about DID mode, and we did, this is the family pedigree, these 2 patients, female sisters, and the third sister presented after that, showing that this patient, when you have diabetes, optic atrophy, neurogenic bladder, polyuria and polydipsia, you think definitely with Wolfram syndrome, the classical type, and we did a deletion, and it was with a novel mutation. The 7th case also is at the age of 15 years, 9 months, persisted for evaluation, and this patient, what is important, you have to think about GI symptoms if you have to think about Wolfram syndrome type 2. Because these patients were running between the gastroenterologist, pediatric gastroenterologist, taking Nexium and all these medications, and they were missed. And then when you catch them, you think that you can catch up this diagnosis. He used to have GI symptoms: duodenal, gastric ulcer, esophagitis, diabetes mellitus, diabetes insipidus, tetralogy of Fallot, and genetic testing was done showing that this patient has a Wolfram syndrome type 2. The 8th case, he presented to Maqasid Hospital, and in the neonatal period, he showed the detailed ultrasound, showed the suspected duodenal atresia, the double bubble sign, severe polyhydramnios, IUGR, and we investigated him, and we investigated him thoroughly, and he had the problems list: neonatal diabetes, IUGR, pancreatic agenesis, duodenal web. So we did a molecular analysis. We thought about PDX1, and we have a mutation, novel mutation of PDX1, and we thought that we have a lot of novel mutations happening at Makassar, so we have to think about publication. So I called Khalid at Qatar, and he was in the way doing his lab, having 1 million here, 1 million here. So he, as he told Riyadh Qatari, or from here. So I asked his help. So he is now doing for us functional studies to have a proper participation and to put it in an index journal for this PDX mutation. So also we did segregation study, and this is about PDX1 gene. And after a while, few months, we have the same family member with the neonatal diabetes, and we also now with his neonatal diabetes, the same family member, it's PDX1, the same gene. So we are waiting for the functional studies for publication with Khalid, and Khalid is following for this case. Ninth case, it's a 5 months old infant. Product is presented with congenital hypothyroidism, cholestatic jaundice, neonatal diabetes, failure to thrive, congenital hepatic fibrosis, and renal abnormalities. So we thought that we will have a quick diagnosis, and at that time, we thought about GLIS3, because we have a congenital hepatic fibrosis. It's directly, we have to go for GLIS3. We did the primers, and we did sequencing the gene, and unfortunately, we did not find it. So we sent it to Exeter, and Exeter sent us this answer that till now we don't have a diagnosis for this patient with neonatal diabetes. And this is the next patient that will Khalid take care of him from here. Yes, okay. So these cases now, they presented 10, 11, 12, that they presented diabetes mellitus, hyperpigmented skin lesions over trunk and lower limbs, hirsutism, and coarse facial features and joint pain. Just to make the story short, this is the problem list: hyperglycemia, short stature, hypertrichosis, hyperpigmentation, a heart failure. They presented with the syndrome of H syndrome, the gene of SLC29A3, and we have a 3 mutations for 3 patients. And if you can see here that this one described previously, but we have another 2 novel mutations. So we add these novel mutations to our list, and these are these mutations done at the molecular lab at Makassar Hospital. And this is the last case. This patient presented at Makassar Hospital with the IUGR, duodenal atresia by detailed ultrasound, and positive family history of duodenal atresia, SGA, and we did extensive work up for him, and this is the problems list: IUGR, intestinal atresia, neonatal diabetes, anemia, cholestatic jaundice, pancreatic insufficiency. So we have a novel mutation, Mitchell. So this is the mutation, it's a homozygous, and this is the mutation, this is the control, and the patient sequence. So in summary, these are the list of our patients. If you can appreciate the age of a diagnosis, most of them, they are consanguineous, of Palestinian origin, mutations identified, either missense, stop codon mutations, or a deletion. And if you can see the list, the third one, which is, I am proud of telling that it's novel mutation, novel mutation, novel. It is a non-mutation. Within the list, we can appreciate at least 9 novel mutations. Most of them needs publications. We can share to have a review about the monogenic diabetes in our area, in the Palestinian population, and this is the final diagnosis. Still, we have to go with the list for that one that is not diagnosed, the diagnosed, and for more patients, or to collaborate. We're talking about our population and the incidence in our area. So in conclusion, it is not monogenic. It's not very uncommon. Higher rates of consanguinity predicts higher risk of monogenic. Monogenic is often misdiagnosed or type 1 or 2 diabetes. Diabetes diagnosed before 6 months of age will be monogenic diabetes, and the underlying gene mutation can be identified in most of the cases and guide the most appropriate management for patients, enabling genetic counseling, correcting the diagnosis of other family members as in part of our patients, and helping them explain other associated features, predict the clinical course of the disease of these patients. And always, I have always said, we have started at Makassar, now we are expanding our expertise. and we are willing to do also we can do any gene sequencing for any gene if we suspect, and we can have the result within a few days. And as Benjamin Franklin said, if everyone is thinking alike, so there is no one thinking, think out of the box. This is, I was diving to bringing more mutations down the sea. This is Jerusalem, this is Palestine. Thank you.
Okay.